Today's abstract was a presentation about the first in-human study on AMG 420. It's a bispecific antibody construct utilizing as target structure multiple myeloma BCMA. BCMA is a receptor that has been in the focus of myeloma and is being now addressed by 3 different ways, either through immune conjugate. That is data that has been presented before with a response rate about 62-63% in the patients. And there are the CAR T-cell field that is also engages with BCMA CARs. There's been a New England paper just very recently published showing also response rates of CRs 45%, with the majority of the patients over being MRD negativity. And the last way of exploiting BCMA expression is by using the bispecific antibody platform, the BiTE technology, and now this is the first in-human study and offered dose escalation phase 1 trial. The primary objective was to identify the MTD and the safety and tolerability, and the secondary endpoints would be, of course, anti-tumour probabilities of this novel concept. So the MTD was reached, which was at 800 micrograms per day, continuous infusion. We saw 2 patients who classified to be having a DLT. One had a cytokine release syndrome, grade 3, but which resumed very quickly after stopping the drug within 48 hours back to baseline. And the second patient developed a polyneuropathia 3-4 weeks after initiating treatment, which needed also IgG infusions and steroids to be treated, but then also return back to baseline. In terms of the safety profile, what we saw were actually 2 signals. Cytokine release syndrome, the vast majority was just grade 1, treated just with paracetamol. There were 2 patients with grade 2 cytokine release syndromes, which needed then dexamethasone, and there was just that 1 DLT patient who had a cytokine release syndrome grade 3 by the CTCA4 criteria. And the second signal that we saw was safety, was infectious complications. Particularly, we lost 2 patients on the clinical trial due to infections, one with a aspergillosis on bottom of a influenza infection, and then the second patient due to a adenovirus infection of the liver. And there were a couple of other patients with chest infections, viral related, and some central venous line infections. So in terms of the efficacy, so the first patient that responded on this 3+3 dose escalation design was at 6.5 micrograms per day drug, who reached then a very good partial remission. And then as we were escalating, we saw at several other dose levels single patients responding. But once we crossed the border at 400 micrograms, 3 patients out of 3 in the DLT evaluation period had a response. And then once we then also went up to 800, then went back and had a mini expansion cohort, we saw an additional 4 patients responding at 400 micrograms per day. So overall, the response rate at the suggested dose of 400 is 7 out of 10 patients. What is really meaningful, 5 of them had a MRD negative CR measured by flow cytometry. And the vast majority of those patients are still on continuous response. We only just had 2 patients who actually have had a relapse in that situation. So that is the one very important point of this trial, that in the dose limit, the dose of 400, we had 7 out of 10 responding. And the other thing that we also saw, which is that there were 3 patients where we prematurely stopped AMG 420. 2 of them had the polyneuropathia, So we had to stop treatment in the first cycle. And then we had one patient who stopped treatment due to ID problems on cycle 4. They were allowed to get 10 cycles. And all those 3 patients are still in continuous remission. And with only really a short period of treatment of maybe just 3 weeks. So we don't know exactly what that means, but this is obviously something that we would like to investigate in the upcoming phase 2 trial, which has already started now, and where we hope to really consolidate this really nice results.
Yeah, thank you. And in what way do you think the results may impact clinical practice in the future?
It's an excellent question, of course. The field in myeloma is quite crowded. So the current phase 2 trial is going to be in patients who are double refractory to IMiDs and proteasome inhibitors, and also don't respond anymore to daratumumab. So that is actually quite a sick population. But that's just a registration trial, single-arm trial. In the bigger picture, I feel AMG 420 may have a role in treating MRD-positive myeloma after frontline therapy. It is, as it applies a different mode of action than the current ways of putting a patient into remission. So that's one way I would envision it. Or it could be also sequentially in the consolidation cycles in multiple myeloma after using modern induction regimens like KRD and daratumumab, for example, plus minus high-dose chemotherapy. This could also be another way of actually using consolidation cycles and sequentially using that with KRD and AMG 420. So that's my personal vision of it. We'll see what happens then down the road.